You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Domson, welcome back to the Nailed It Ortho Podcast. So happy to have you on. It's been at least 2 to 3 years since you've been on the podcast.
Happy to be here. I'm glad to get the Christmas greeting from you and happy to be back on.
Yeah, and today we're going to talk a little bit about more malignant cartilage forming tumors or chondrogenic tumors. But before we get into all that, we kind of asked a couple of questions to get to know you a little bit better. And for those of you that haven't listened to our first episode, go back and listen to our first episode, Dr. Thompson. And now we're actually gonna talk a little bit more about some cases, maybe some interesting cases. So I guess the question I have for you: what's the case that you like to do? A kind of classic case, or that you see this on the board, or you're planning for this, you're like, okay, this is like a case that I love to do.
It's a good question. I haven't thought about it too much. I mean, sometimes, in my home place in Richmond here at Virginia Commonwealth University, I have a 3 and a 5 on the service. And so sometimes I like having simple cases so the 3 gets to do them, even simple lipomas or femoral nails for prophylactic femoral nails for metastatic disease, stuff that the 3 can get excited about, and we can really kind of get them involved in doing something that's in their wheelhouse. And it depends on how things are going. You can't do hemipelvectomies your whole life. It's just too much. So sometimes you need a break. Sometimes you need some chip shots or some layups, and then other times you're like on a hot streak of doing big tumor resections and distal femurs and proximal femurs. And I do like doing a proximal femur. I think it's a good dissection, and you see a lot of anatomy, and it's good for the residents to see a lot of anatomy in a proximal femur. But I went into the oncology for the mix of cases, so I like a mix. I like doing lots of different things, to be honest with you.
Yeah, and on the flip side of that, what is a case that you see, you're like, okay, I know this is going to be a challenging case, like I better prepare for this, but at the end of it, it may be a long day. You're like, okay, I'm glad, it's somewhat rewarding at the end of the day. Do you have any cases like that?
Yeah, internal hemipelvectomies are like that. You're like, sometimes I've been doing this for 17 years now, and still sometimes before an internal hemipelvectomy, you're like up at night thinking about it and going over the steps in your head and looking at anatomy and looking at the MRIs and figuring out what's going to be the holdup and where the anatomy is pushed by the tumor. And so those are probably the real big ones. External hemipelvectomies and 4 quarters, those things are fun, but it's still an amputation. But trying to preserve everything and get margins and then get your reconstruction with an internal hemipelvectomy is a big one.
Yeah, I will say I have never seen one of those done. I've only seen the pictures from and everything's from talks. My co-resident went into oncology and he's in fellowship now, and he's done a couple of them. But I still have yet to see one, and I and I doubt in my sports career I will see one. But hopefully, I've heard the stories of how the cases go. So they're very interesting cases.
Yeah, sometimes I'll tell the residents, you can call your parents and tell them you're never going to do this again.
Right.
Call your dad and tell him you did an internal hemipelvectomy today.
Man, yeah, those have to be crazy. Just cases that take a lot of stamina. But anyways, so switching gears and kind of getting into today's topic, we're going to talk about some malignant cartilage forming tumors. And maybe you can kind of just take us through how do you approach these, or how do you think of these in your head, and then we can talk about a couple, some of the different tumors and their different characteristics, and touch on the high yield points that we all need to know.
Yeah, it's a good topic. I get a lot of questions, especially from the chiefs and the upper level residents who are going into joints. They're scared they're going to put a total hip in a chondrosarcoma or miss a chondrosarcoma on an X-ray and end up doing something. That they have this fear about chondrosarcomas, and they've seen kind of disaster cases. So we'll try to make it a little bit practical from a practice standpoint, but also maybe get some test questions right. I just got the OITE results back. It was a hard test. The tumor was hard this year, actually. There's 20 tumor questions, and the national mean was not very. Normally, the tumor questions are pretty easy and people do well, but it was hard this year. So maybe we'll get a couple questions right as well as we're moving through it. But it's interesting you said cartilage forming tumor. So I want to start with a case. There's an interesting case that kind of illustrates some points about chondrosarcoma. And we have a relationship with some of the islands down in the Caribbean, and take care of some of their, weird cases that need, help, or strange things. And we got a case from down there of a teenager, like a 15-year-old kid, who had a chondrosarcoma of the tibia. And the bottom line is that should be a total red flag. 15-year-olds do not get chondrosarcomas.
Yep.
And so, the second they sent me this consult, I thought to myself, that kid's got a periosteal osteosarcoma. Okay. So in the back of your mind, you have to realize that you can have osteosarcomas that make cartilage. They can be chondrogenic, and you can even have periosteal osteosarcoma, which makes a lot of cartilage. Sometimes cartilage will be the predominant cell type in a periosteal osteosarcoma, and they're oftentimes in the tibia. But what you got to remember in general is that young people really do not get chondrosarcomas. Okay, so I kind of tell my residents, if the patient is younger than 50, chondrosarcoma should be way, way down your differential. Really doesn't happen in younger people very often. It can, and crazy things happen, but in general, that's something you have to think about immediately. I tell the residents, when you come up with these differential diagnoses, it's like a big Venn diagram in your head. You've got a bunch of circles. People who are this age get this. People, this bone gets this. And really good orthopedic oncologists can put those Venn diagrams together and make an incredibly good differential, which sometimes just has the one right diagnosis. And age is obviously an important thing to consider when we talk about any tumor, and certainly in chondrosarcoma. Young people really do not get them. Okay, so 15-year-old chondrosarcoma of the tibia, it's a periosteal osteosarcoma. Okay, and if you're in your 20s and 30s and really 40s even, it's really chondrosarcoma shouldn't be high in your differential. And when you start getting older, you start getting your 50s, 60s, and 70s, it's going to start popping in there. And especially as you start getting more, pelvic tumors and axial tumors, chondrosarcoma is really going to start getting higher on your differential and should be considered more than in the younger people. So that's kind of the first point I want to make.
Okay.
Is that think about age first, and really there's only one type of chondrosarcoma that younger people get, and that's a clear cell chondrosarcoma. And just to touch on that real quick, clear cell chondrosarcoma, you can kind of think of chondroblastoma, the same type of location. It's almost an epiphyseal metaphyseal tumor. It's going to be a lytic lesion, maybe have some chondroid matrix in a little bit of a younger person, maybe in their 20s and 30s. I think on your slide you have them a little bit older, but clear cell chondrosarcoma definitely is going to be the only one you really see commonly in a younger adult. Okay, that's the only time I really want to hear you say, "Oh, my differential includes clear cell chondrosarcoma." That's going to be an epiphyseal lesion in a younger adult that you would have been thinking chondroblastoma in a young person, in a really young person. Okay.
And what are the ways to differentiate that, right? Just like you just said, most of the time you're thinking chondroblastoma. So how are we making a differentiation between chondroblastoma?
You can look, you can look at the age of the patient, number one. If they're older, you're going to be thinking more clear cell, but you can get chondroblastoma, in a little bit of an older person too. Really, you got to biopsy them to really clinch your diagnosis. But I think age is probably your biggest differential, just looking at imaging. And certainly chondroblastoma, you're thinking somebody in open growth plates. Okay, so the growth plates are closed, then you're thinking more clear cell chondrosarcoma. If the growth plates are open, you're thinking more chondroblastoma.
Okay.
So again, it's an age thing, all right? But people with open growth plates don't get chondrosarcomas. They just really don't in general, okay? So, and then even in younger people, the only thing you're going to get is a clear cell chondrosarcoma, which you're going to figure out from its epiphyseal location. But so now let's just talk about, so a couple things to think about, but just talking about now standard chondrosarcoma, the cells break bad and they go down the pathway of becoming cartilaginous type cells, but in a malignant fashion. Okay, so primary chondrosarcoma, more common in the axial skeleton. You're going to see in the pelvis or scapulas than the appendicular skeleton, but you can certainly get them in both places. And We're not talking about any of our other pre-existing conditions right now. Okay, so forget about Olier's disease, forget about multiple hereditary exostosis, forget about Maffucci's right now. Okay, we're just talking about somebody gets bad luck and develops a chondrosarcoma of bone. You can have grade 1 chondrosarcomas of bone, and even the Mayo Clinic has grade 1 half chondrosarcomas. Okay, so this is the test question is, how do you tell the difference between an enchondroma and a grade 1 chondrosarcoma? You can't really tell in the pathology. This is one of the few times the pathologist doesn't get the final say in the diagnosis. You tell by clinical and radiographic correlation if they start having pain, if the tumor is growing, if it's changing over time on radiographs, if the patient starts to develop symptoms. That's how you're going to tell if something's an enchondroma versus a grade 1 chondrosarcoma.
Yeah.
But you're still going to have pretty benign findings on your imaging, and you're still going to have pretty benign findings on especially on your pathology. So a lot of those cases, we don't even biopsy these people anymore because the pathologist inevitably comes back and says low-grade cartilaginous neoplasm. And how is that? And basically what they're saying is, look, buddy, I'm not in charge of making this diagnosis. You are. So, you can look at a lot of the imaging and you can say, well, they're going to say low-grade cartilage. We have to decide with the patient whether or not we're going to do anything. And most of the time, you can find something else from an orthopedic standpoint causing those symptoms, especially around the shoulder. It's almost never the tumor. But sometimes it is, and sometimes you got to scrape them out for those grade 1 chondrosarcomas. A grade 2 chondrosarcoma is going to look worse on X-ray and imaging. Okay, it's going to have periosteal reaction. It's going to have scalloping. It may have a little bit of cortical breakthrough, a little bit of cortical expansion. So not super aggressive, but also, you can tell something's amiss, And the same is kind of true of the pathology. If you can look at the pathology, you can tell it's cartilage, but you can tell the cartilage is acting funny. It's kind of breaking its way through the trabecular bone, and there's more lacuna, there's more cellularity. You can kind of tell. You can tell it's cartilage, but you can tell it's also not a grade 1 or a low-grade cartilage tumor. And grade 2 chondrosarcomas are treated with wide excision. In general,
one of the things that you mentioned for grade 1, you mentioned cutting it out. You mean doing a curettage as far as your treatment for your some of your grade 1 lesions?
Yeah, so your grade 1, I scrape them all out. I use the burr. I tend to use the argon if I'm a little worried. Probably if you look at the literature, the best thing to do for a grade 1 chondrosarcoma is pour liquid nitrogen in there, but I just don't like freezing the bone completely if I can help it. And so I don't tend to use cold for that. Some people do. I tend to use heat. Low rate of recurrence. I think if you do a good job of your curettage and burring and everything else, you're going to have a low rate of recurrence of those grade 1 chondrosarcomas.
Yeah. And you're saying for grade 2?
Grade 2, I do a wide resection for all of them. No chemotherapy, no radiation. In general, cartilaginous tissue, if you think about it, has kind of a low metabolic activity. They're cells that don't do a lot. They don't, they're not real active in general. And so chemotherapy and radiation just aren't going to work on cartilage cells in general. And clinically, they don't tend to work. So grade 2, I just do a wide resection. Grade 3, things are going to look bad. There's going to be a soft tissue mass. There's going to be bony destruction. You might even think it's something that's not even a cartilage tumor. You might think it's something else like a MFH of bone or an osteosarcoma or something else. So it's going to look really aggressive. And again, if you get cartilage tissue back, you're going to hardly be able to tell that it's even cartilage tissue on the pathology. It's just going to have a little bit of that chondroid matrix, but the cell's going to look really ugly. And again, it's going to be wide resection for those. You can send them to hem-onc to be considered for chemotherapy for grade 3 chondrosarcoma, but it doesn't tend to work very good. So hopefully those patients are non-metastatic. You get a wide excision and you cure them with surgery alone. So that's just your primary chondrosarcomas, okay? A rise in bone, axial skeleton, more common than appendicular skeleton, no pre-existing lesion, no pre-existing condition, just bad luck, old patients, okay?
Yeah, I remember when I was studying for the test, almost most of the questions where they showed like a chondrosarcoma was right around the pelvis or, hip region, like right around that. I don't know if that's how it typically is in real life. I know you just mentioned kind of some locations, but at least what I've seen on many of the questions when I was studying for the boards, it seemed like almost all the stuff was around the pelvis
Yeah.
ended up
And,
being
that, and that's
chondrosarcomas.
and that's why the joint guys freak out. You know what I mean? These guys are finishing their fifth year, finishing their fellowship, and they're like, I just don't feel like putting a total hip in a chondrosarcoma. You know what I mean? So
Yeah.
they see a little subchondral cyst. It's just fine. It's just a subchondral cyst. You know what I mean? You're going to be okay type thing. And I get it. That's a reasonable anxiety to have. It's something to worry about. And certainly, I give a talk at the Virginia Orthopedic Society meeting every couple of years, and it's the title of the talk is "You Don't Want to Get Into This Business," and it goes through a bunch of cases that are just crazy cases of tumors that were either missed or were there, but God, you barely could see them. And so, you do have to have a system when you get out into practice on how you look at your X-rays because you don't want to miss something bad. And so, you got to have a checklist of how you look at X-rays. And one of the last things on that checklist may be look around for a tumor, look around the edge of the X-ray, look at the ribs. If you're looking at a shoulder X-ray, make sure you have a step in there where you're trying to cover your bases for not missing something that might bite you sometime in the future. So that's another piece of advice I'd give to people just coming out into practice. And some of these cases, just for your benefit, some of these cases I show are sports cases. They're
Yep.
sports cases that were actually tumor cases. And so you got to be vigilant. You got to get yourself in the habit of being thorough, looking at your imaging studies, because as much as you'd want to trust your radiologist, you can't trust them all the time. So that's a little bit of a side, just some general advice on when you get into practice and how you do things. But
Yeah.
so um, pelvis is more common. Chondrosarcomas tend to be more aggressive in the pelvis. That's another rule. And so even if it looks, not that aggressive on imaging, chondrosarcomas in the pelvis tend to act more aggressively than ones in the appendicular skeleton. So something to think about in your treatment options. You probably want to treat them more aggressively as well surgically. So now what you're going to see in a lot of tests is secondary stuff. Okay, and so one of the big things is people getting an enchondroma, and we know enchondromas are really common. Getting a secondary malignant cartilage tumor from a pre-existing cartilage lesion. So let's just talk about enchondromas. And if you look at a lot of chondrosarcomas out there, you can oftentimes see what looks like to be a pre-existing enchondroma or the remnant of an enchondroma, maybe on X-ray or CT scan, and now you've got something bad underneath there. And
Yep.
certainly enchondromas can kind of degenerate into a grade 1, 2, or 3 chondrosarcoma. Okay, they can transform into that, but they can also de-differentiate. So that's two separate things. Okay, you can have an enchondroma, a pre-existing lesion that transforms into a grade 1, grade 2, or grade 3 chondrosarcoma, or you can have an enchondroma that de-differentiates. And the point there is that in a de-differentiated chondrosarcoma, you have this benign looking cartilage tissue from the enchondroma. And then right next to it on the slide, you have a high grade soft tissue sarcoma. You have, starry night. You have a pleomorphic sarcoma with a storiform pattern and ugliness and the whole 9 yards you already learned about. So from a pre-existing lesion, an enchondroma could just become a grade 1 chondrosarcoma. You treat it with curettage. It could become a grade 2 chondrosarcoma and you do a wide excision. It can become a grade 3 chondrosarcoma and you're going to do a big wide excision, or it can de-differentiate where it goes completely haywire and becomes a high grade sarcoma right next to benign cartilage tissue. Okay. We're seeing a lot of D-diff chondrosarcomas, and they're very bad actors. The 5-year survival rate maybe is 10%, probably, 5 to 10% 5-year survival rate for D-diff chondrosarcoma. And chemotherapy really does not work on it. They can try chemotherapy, but it doesn't work very well. So hopefully you find those people early and you get a wide excision and you cure them.
Yeah, I think
So
that was a good point that you just brought up because I know it took me a while to really even figure out the difference between something transforming into, just like you just mentioned, like an enchondroma transforming into a low-grade chondrosarcoma versus de-differentiating. And then just like you just mentioned, they always showed you they give you a slide and they show you that like you just did a high grade sarcoma right next to like that benign lesion. So that's a good point that you just made there.
Yeah, that's one of the things that confuses the lower level residents. Okay. And again, I call it a biphasic slide. There's two types of biphasic slides, but this one is the slide is cut in half, and on one half of it is benign cartilage. On the other half of it is a pleomorphic sarcoma, starry night, storiform pattern. The other one that you get the biphasic slide, now that we're kind of on the topic, is a mesenchymal chondrosarcoma. Okay. A mesenchymal chondrosarcoma, you have benign cartilage tissue on one half of the side, and on the other half of the slide, you have a small round blue cell tumor. Okay, so a D. diff is half benign cartilage, half pleomorphic sarcoma. Mesenchymal chondrosarcoma is enchondroma, benign cartilage right next to a small round blue cell tumor. Those, maybe you want to do chemotherapy, wide excision, and maybe they do a little bit better than D. diff. I guess I haven't looked at the 5-year survival from mesenchymal chondrosarcoma in a while. They're very rare. I haven't had a mesenchymal chondrosarcoma in years. D. diff chondrosarcoma, I did a distal femur for D. diff chondrosarcoma like 3 weeks ago. So they're much more common. We're seeing those more commonly. And kind of to break my rule, that lady was right around 50, so a little bit of a younger woman. She had a pre-existing enchondroma. And when I looked at her radiographs, I'm like, oh, this might not be terrible. Maybe this is a grade 2, or maybe we caught an early grade 3 transformation. She clearly had a pre-existing enchondroma. And we took the specimen. I didn't even biopsy her. I knew it was a enchondroma that had broken bad to some level, and I knew she needed a wide excision. So we just did her wide excision, and her final path came back with areas of dedifferentiated, chondrosarcoma. So that's no good for her. Hopefully, we caught it early, but so that's one thing. Enchondromas can transform or they can dedifferentiate. Okay. Now let's talk about. Olier's disease obviously is enchondromas everywhere. Okay, so these patients have enchondromas all over their skeleton, and so they have a high risk of, much higher risk just from the sheer number. But one thing I want you to know is that cartilage tumors of the hand and feet are almost, especially the fingers and digits and toes, are almost never malignant.
Okay.
They can look more aggressive radiographically. They will look more aggressive under the microscope, but they are hardly ever, ever, ever malignant. I've taken off one malignant enchondroma of the digit in my whole career. It would end up not being an enchondroma. It ended up being a low-grade chondrosarcoma in my whole career. So even with Olier's, they can have a bunch of hand lesions. With Maffucci's, they can have a bunch of hand lesions. They can look ugly. They can have fractures, but they're hardly ever, ever, ever malignant. Okay? But all the other ones can break bad. They can transform or dedifferentiate just like any other enchondroma. Okay. So obviously,
is there with those conditions, are there any conditions that increase a chance for having any type of malignancy in the future?
Well, Maffucci's, as you know, is basically 100% chance of developing another malignancy. Yeah. But that's not always a chondrosarcoma. They can develop colon cancer and all kinds of stuff. Okay. But a lot of times it is the chondrosarcoma because they have got Olier's everywhere and they're clearly missing a tumor suppressor gene. Okay. Maffucci's people are in a bad spot, but you just have to keep an eye on them because they have so many of them. Yeah. Okay. Maffucci's, you got to keep an eye on everything because they'll grow a cancer of any kind anywhere practically. So let's just switch gears to multiple hereditary exostosis. Again, this is a benign cartilaginous tumor. You get this cartilage cap as you get older. That cartilage cap tends to thin out and go away. And some people, that cartilaginous cap sticks around even into their, adult years. And we have kind of these guidelines if the cartilage cap is too thick, but really if that cartilage cap starts to grow, then you really got to probably do something about it. And when you have patients with multiple hereditary exostosis, they've got osteochondromas everywhere. And some of them, may have cartilaginous caps and of different thicknesses. The big thing is going to be, is it growing? And if they start having growth, that thing's clearly got to go.
You're talking
Probably
about the
if
cartilaginous cap. If
yeah,
the
yeah,
cap
yeah.
itself is growing.
Right, the bone's not going to grow once they reach skeletal maturity, but some of those
Mm.
cartilaginous caps stick around. And if they start growing, they gotta go. Okay, especially in someone with MHE, they may have a bunch of them still with caps on there, but any sort of growth, that thing you got to take out, and probably it's going to be its own diagnosis. It's going to be like a chondrosarcoma of multiple hereditary exostosis origin because they tend to act very benign. They don't tend to metastasize. They don't tend to recur. If you get them out of the margin at all, the odds of them coming back are quite low. So it's a manageable type of tumor. You just got to you got to keep an eye on your MHE patients because they have lots of them a lot of the time. They have a lot of pain complaints too. They've got deformity, they've got joint issues, and so sometimes it's hard to differentiate. Like, are you hurting because you're hurting, or because you've got a tumor? And so sometimes you got to use MRI to follow these people. I had a guy come in just Monday who was there for his yearly MRI for me to keep an eye on some of these cartilaginous caps that we're a little worried about.
Okay.
But those tend to be more manageable cartilage tumors. And then, as I said, they're almost going to be their own class of kind of low-grade chondrosarcoma from a pre-existing osteochondroma.
Now, the pre-existing, that doesn't, like, for example, if you get a chondrosarcoma from a pre-existing tumor versus if you just have a conventional chondrosarcoma, are any of those, or one or the other, more aggressive or more malignant, or are they all, at the end of the day, it's a chondrosarcoma, or is
Yeah,
one worse than the other?
the only one is the ones from osteochondromas tend to be really wimpy. Otherwise, it's whatever that thing's acting like. If it's
Yeah.
acting like a grade 3 chondrosarcoma, you're in bad shape. If it dedifferentiated, you're in bad shape.
Ah, okay.
Re-
Okay.
really, really grade 1s do fine. Grade 2 chondrosarcomas, if you get them early, they tend to do pretty well. But grade 3 and D diff chondrosarcomas do not do well. You do not want that diagnosis if you can help it.
And you mentioned on the mesenchymal, for the mesenchymal chondrosarcomas, that again, most of the treatment's pretty much wide surgical excision, but in some cases, there's some reports of chemo or radiation helping. Is it just because it's helping the ron blue cell part of that tumor, and it's still the chondrosarcoma part is it's not
Yeah,
really being affected?
yeah,
Ah,
thinks
okay.
exactly right. But I
Yeah.
still don't think they have a very good 5-year survival. I'll have to look that up. I don't know off the top of my head. They still don't do great. High
Yeah.
grade
Okay.
chondrosarcoma is bad. Okay, just the bottom line is that cartilage cells that act that aggressively, and they're just not responsive to our other treatments. Um, so you got to get them. You got to get them early surgically and hope for the best.
Okay. And then you mentioned clear cell a little bit earlier when we were talking about kind of the younger patients that have these chondrosarcomas, and then we mentioned chondroblastoma, but that's more, skeletally immature, open physes. Anything necessarily different about the treatment for the clear cell chondrosarcomas, or anything, or what necessarily makes it a clear cell? Is it just how it looks under the histology versus like these mesenchymal
Yeah,
chondrosarcomas?
yeah. They're so clear cell is going to have clearing inside the cell. Okay, you're going to have cytoplasm, nucleus, and a clear space in between the two. Whereas chondroblastoma, which is a benign entity in kids with open growth plates, when they talk about that stepping stone appearance or fried
Hmm.
egg appearance or cobblestone, there's a little clearing around the cell on the outside of the cell where the cells almost pull away from each other a little bit. And that's what gives you that kind of classic chondroblastoma pathology. Clear cell chondrosarcoma, the clearing is inside the cell, just like you would see in clear cell renal cancer, okay? And the treatment's still going to be wide excision for your clear cell. And then it's more of an intermediate grade tumor. The patients tend to be younger, so the hem-onc people kind of want to give them chemo. Certainly, if you have metastatic clear cell chondrosarcoma, they're going to give you chemo. But if you don't have metastasis, they kind of hem and haw. They'll still probably end up giving it because the patients are younger and can withstand it. But it's more of an intermediate type of lesion from aggressiveness.
Yeah, I remember this would have been so helpful when I was a, a junior resident, because I remember I used to know, okay, this is chondrosarcoma. But then when you go in the answer choices, it's never just chondrosarcoma. It's clear cell versus mesenchymal versus dedifferentiated versus secondary. So you need to know all the different
The,
types that you've explained.
yeah, this is one of the lectures where I'm giving the lectures and people's eyes are like glazing over. I'm like, oh boy, they're just not getting it, you know? So I thought it'd be a good topic for tonight.
No, no, I think it's super important to know and be able to definitely figure out the difference between, and again, I really like how you explain the difference between something that kind of transforms versus de-differentiated chondrosarcoma. But anything else that you think that those studying or those that are interested in oncology or anything should know about these, I guess, these malignant chondrogenic tumors?
I think you just got to remember. I mean, certainly it just goes back to the basics of tumors. You know, your X-rays represent a lot of times what's going on. You know, at a microscopic level. You know, is there bony destruction? Are there rings and whorls? Or what kind of matrix can you see on the X-ray and CT scan? And then also, what kind of cells are these? We know that chondroid tissue doesn't even need a blood supply, right? It's kind of this cell that just sits in its chondroid matrix. It gets hyaline cartilage at least gets nourished by joint fluid. It metabolically is not very active. We wish it was, so you could repair cartilage better, you know. And chemotherapy and this radiation are not going to work on chondrosarcoma, and so it's mostly a surgical disease. But it's for me, I always try to get the residents to think about the microscopic biology of the tumor and how it's going to predict, behavior and outcomes, and also how it shows up on X-rays and imaging. There's hints to those things, and they're correlated. You know,
Yeah.
an X-ray is looking at a biologic entity, and it can give you a lot of hints. It takes time. It takes experience. You know, the first and second years are just trying to get sleep. But this stuff sinks in after a while. But certainly, chondrosarcoma is one of the more little bit confusing things in oncology. You know, oncology is interesting because there's not a lot discovered in oncology. You know, people have been getting giant cell tumors for thousands of years. They've been getting chondrosarcoma for thousands of years. It's not like some new tumor has suddenly popped up and started plaguing human beings since we've been
Right.
alive. All this stuff's been around forever. And sadly, I mean, I think there has not been a ton of advances in orthopedic oncology in the last 20 years since I've been doing this. There have been some, but we haven't started curing chondrosarcoma, I can tell you that much. So most of the time, tumor is a pretty straightforward portion of the test. Guess was pretty hard this year, but
Yeah, so hopefully those that are listening, at least that have listened to this podcast, these are other podcasts and on working up lytic lesions. Anytime any of these questions come up on the test, hopefully you should be able to remember and get those questions right. Dr. Domson, this has been again great having you on the podcast and talking some more tumors, some more, and now talking chondrosarcoma. I mean, we talked about all the different types of chondrosarcomas, the age range. We talked about where the lesions are, what they look like under histology, and the treatment of it. Again, great episode. And for those that are listening, please go and leave us a review or a like, and however you listen to us, let us know how much you enjoyed this episode. And again, Dr. Domson, thank you for coming on the podcast.
it's my pleasure. I'm happy to come back again. Let's not wait 2 or 3 years this time.
Right.